Welcome back to the PFC podcast. The views and opinions you are about to hear are the speakers and do not necessarily reflect those of anyone else. Now on to the podcast.
Welcome back to the PFC podcast. This is Dennis, and today I am with Doug. How you doing, Doug?
I'm good, Dennis. Thanks.
So the reason why I asked you to come on is you're an ICU doc, and you're a very busy ICU doc. And so because of that position, you guys are definitely into labs. So today I would like to get your advice on labs that are important for the austere environment.
Awesome.
Let's kind of, I guess, set the situation. Let's say I'm going to go on a JSET to, I don't know, Africa, somewhere, a country in Africa. And I'm going to bring a ventilator. I have some monitor, like a Tempest Pro or a ProPack or something like that, a monitor, cardiac monitoring device. I don't really have room or desire to bring like a microscope and things like that. But I do know I'm probably going to need some kind of lab capability to go with my maybe some more advanced interventions like setting up a vent or something like that. So, in your experience, what labs are going to give me the biggest bang for the buck?
Well, to start off with your JSET location, the first, second, and third lab that you need to have with you is something to test for malaria, like the Binax lab,
Okay.
because that's one critical piece of information that will help you with diagnosis and management and evac planning. That's fairly common there. That can masquerade as a bunch of different things. And so if you can single out malaria, that would be super helpful.
Yep. I have cases of Binax tests.
Fantastic. I figured you would be so well prepared, but I never want to ignore the obvious when you start talking about the more esoteric.
Yep.
So moving on to that there are really kind of two scenarios where labs are helpful. And one is the critically ill, critically injured scenario with your unstable patient. And then the other is sort of more general clinic diagnostic labs. And the nice thing in reviewing the two most commonly used and well-validated point-of-care lab systems is that both seem to offer the same capability in both of those avenues. So we'll start with critical care since you introduced me as an intensivist, and you're right, I've been practicing quite a bit this week, and depending on labs, quite a bit. The most important lab for the acute management, of the unstable patient and making minute-to-minute decisions, I think, is the blood gas. And the blood gas contains the pH, which is super important, and I'll break down the importance of each in a minute. An ionized calcium, and then your PCO2, your partial pressure of carbon dioxide, and your PO2, your partial pressure of oxygen. The latter two are helpful for both determining, whether helping you make a decision to take the patient's airway and put them on a ventilator, as well as for managing a ventilator setting. The pH is helpful for a bunch of different reasons. Mainly, it tells you, how sick your patient is. And by sick, I mean, how advanced their shock state is, and are they in anaerobic or aerobic metabolism. And normal pH is 7.4. Patients generally are pretty well compensated from both hemodynamic standpoint, and by hemodynamics, I mean the function of the heart and the function of the blood vessels. And by the function of the heart, I mean its ability to contract forcefully and pump blood out through the blood vessels to the organs. And by the blood vessels, I mean their ability to constrict when you're hypovolemic, the ability of the blood vessels to constrict and divert your lower volume of blood to the places where it's needed most in the body, specifically the vital organs of the heart, the lungs, and the brain. Below a pH of 7.2, you start getting into troubles with both cardiac output. The muscle just doesn't contract as forcefully at lower pHs, and the blood vessels don't constrict as forcefully at lower pHs. Another corollary with this regarding hemodynamics is that your catecholamine-based pressor medications, specifically epinephrine and norepinephrine, are less effective at lower pHs. And then the other implication of a lower pH, especially in our, military trauma patient population, is that blood loses its ability to coagulate at pHs below 7.2 pretty rapidly. Once you're less than, and this is related to decreasing function of the clotting factors. So, the clotting factors are present in fresh frozen plasma. They're synthesized in the liver. There are whole classes on, what's the coagulation cascade and, clotting factors, 2, 7, 9, 10, 5. There's a whole bunch of them. And they start to lose their effectiveness as early as a pH of below 7.25, where they can drop off by as much as 30% in their ability to stimulate the formation of a blood clot. And they drop off rapidly, to less than 50% and less than 25%, as the pH goes from 7.2 to 7.1, and at 7.0, you are, super coagulopathic. So pH is super helpful because it gives you a snapshot not only of how sick your patient is, but the possible physiologic ramifications of how sick they are, specifically lack of cardiac output, lack of the ability of blood vessels to constrict forcefully enough, lack of pressors to be effective at counteracting both of those two things, and the ability of blood to clot. So I think if I only had one lab that I could take, to my desert island to manage a critically ill patient, it would be pH. Your, PCO2 and your PO2 normals, respectively, are going to be PCO2 of 40. PO2 is a tricky one because everybody, thinks, 100 is good. Well, that's a SaO2. That's your oxygen saturation, and that's different. The partial pressure of oxygen depends on a bunch of things, but, generally, you want it less than 100 is bad. Greater than 100 is good. Sometimes it can be higher. It can be in the 200s, 300s, and 400s if your patient is really oxygenating well. Mm-hmm. Honestly, I think that if you didn't have those, you could manage your patient very well with a pulse oximetry and SpO2 and end-tidal CO2 on end-tidal CO2. But the blood vet CO2 especially can be more accurate than an end-tidal CO2, so that would be helpful.
Right.
And then the last thing would be calcium, because in a hypocalcemic state, that also affects cardiac output and blood vessels to contract. We had a couple of really sick patients last night who were hypotensive, and their cardiac output wasn't very good, and we were giving them push after push of epi, and not gaining a lot of ground, and really started to make some gains when we started giving them some calcium. Mm-hmm, mm-hmm. So a lot of times we'll do that empirically and not have the lab, but if you have the lab, that could help decide whether their calcium is replete enough or not. And there you're looking for values kind of above 1.3 or so. Less than that, probably give more. As you're approaching 2, you've probably given enough, And if you're having problems with hypertension or decreased cardiac output, your answer is someplace else.
Hmm.
I should circle back to pH as well and say that, therapeutically, if your pH is low, then that should be an indication to give sodium bicarbonate if you have it, because improving the pH can improve all of those factors, clinical factors that are affected by low pH, contractility of the blood vessels, contractility of the heart, and coagulation of the blood, and increase the effectiveness of clotting factors.
Okay. So I got a quick question about that. So,
Mm-hmm.
I hear this a lot from, medics. They're talking about, all right, well, my trauma patient, I'm assuming he's acidotic, so I want to give him bicarbonate.
Mm-hmm.
When I ask them, all right, well, what do you expect? Generally, they have no idea other than, well, sodium bicarb is a base, and I'm
Mm-hmm.
going to make him more alkalytic, right?
Correct. Mm-hmm.
Um, I guess I don't really understand kind of forcing that kind of alkalinity on a patient
Mm-hmm.
without necessarily attacking the problem of why is he that way. You know what I
Well,
mean?
you get to the root cause of any, unstable patient, which is, the hallmark of treating any shock state,
Hmm.
whether that's hypovolemic or distributive or cardiogenic, is to treat the shock state. The labs are really giving you an indication of how sick they are, giving you an indication of some things that you can intervene on temporarily while you're treating the cause, because treating the cause is absolutely the right thing to do. But when the body is deranged and out of balance, and metabolism is out of balance, specifically the acid base metabolism, you may need to support that as the body responds, to help the body respond to your treatment.
Okay.
So you never treat acidosis by fixing the acidosis. You treat it by fixing the problem, but you resuscitate by fixing the acidosis. And that's the other hallmark of management of any shock state. It's a two-part solution. Number one, identify and treat the cause, and number two, give cause-specific resuscitation. And we talk about that in multiple discussions we've had about shock, and we think about resuscitation, at the 101 level as giving volume in the form of blood if it's hemorrhagic, or in the form of fluid if it's septic. Potentially adding a pressor, and this is just a continuation of the resuscitation arm of treating a patient in unstable shock.
Mm-hmm.
That make sense?
Oh, absolutely does. But yeah, you're kind of temporarily fixing the situation so that the body can then respond to your treatment.
Right, exactly. You're trying to create better metabolic conditions for the body to respond to the resuscitation. Because if those metabolic conditions are remain, profoundly abnormal, a pH of 6.8, 6.9, 7, 7.1, a lot of the resuscitation that you're giving, as I said, with your pressors, just aren't going to work.
Mm-hmm.
And the other thing that's going on is when, the body is that acidotic, it's sending out alarm bells to the inflammatory system, which is basically causing driving the shock response to become, more and more out of control. And at a certain point, it just gets away from you. And labs, like I talked about, pH, especially, even more so than lactic acid. I mean, lactic acid will tell you, my patient's in anaerobic metabolism, but it won't give you the degree to which that anaerobic metabolism has affected the overall acid-base balance and homeostasis of the body. You could have a lactic acid of 7, and a pH of 6.3, and that's not terrible. If you got the lactic acid, you'd be like, whoa, that's terrible. I got to do a lot of stuff. But you see a pH of 7.3, it's like, I've got some time. They're compensating. They may respond to my resuscitation. You can have a lactic acid of 2 and a pH of 7, and that's a whole different situation. Then you've got, you've really got to pour on support because your patient is slipping away from you.
Right. Yep. Understood. Okay.
Lactic acids are nice to have, but that's why I made the distinction. And when I said, my one desert island lab would probably be pH for treating intensive care patients, that was the rationale for that.
Okay. So blood gas, definitely you want that in your bag, right?
Mm-hmm.
What else? Like electrolytes? What else do you think is helpful?
In certain situations, electrolytes are helpful, right? So potassium for sure in the setting of crush or rhabdomyolysis, that can be very helpful because it adds, a lot of objectivity to, what we've taught previously, which is, feel for, look for, monitor for PVCs, irregular EKG tracings, or irregular heart rate. If you have a pH, if you have a potassium, you can sometimes, in fact, frequently see the potassium elevated before all those abnormalities occur, and potentially institute some therapy for that.
Right. So would electrolytes be your second one going into the bag, or would you want something else?
No, I would say electrolytes would be my second one. Potassium, an interesting one, that I came across and I was reminded of when I was, doing some research for this podcast is sodium. And not so much from a high sodium, but, in a hot environment, in a hot environment, where people are hydrating, if they're hydrating incorrectly and just taking in water without electrolytes, they can actually make themselves critically hyponatremic, give themselves critically low sodium, which can, at the very least, cause them to feel bad. Slightly more worse, it can cause them to have altered mental status as the sodium in brain cells leaves the brain to try to balance out the low sodium in the blood vessels, and the brain cells shrink as water follows the sodium out of the brain cells, and in this severe case can cause coma and death. So if you've got somebody who's brought it in with heat exhaustion or heat stroke, or somebody just found in a hot environment hyperthermic, sodium can give you some indication of how bad that the damage that hypothermia is.
Right. And I mean, that also is kind of a word of caution to any medics that, you find somebody who's in that hyperthermic state, and the old 2 large bore IVs, full send, that may not be the best idea.
Yeah, I mean, if you've got 2 large bore IVs and their sodium is low, and you start infusing a isotonic solution, like Plasmolite or Ringer's lactate, or slightly hypertonic like normal saline, that's actually not bad. If they're really hyponatremic, sodium of 100, 110, and they're really altered, unresponsive, it may trigger you to give them some 3% if you have with them, and correct that hyponatremia more quickly before they spiral into coma and seizures and death.
Yeah, definitely. You want to catch it before that.
Correct.
All right, so we got our blood gases, we got our electrolytes. What about things like hemoglobin, hematocrit?
I honestly don't find those that helpful. I mean, they're going to come on all of these cartridges, whether you're working with an iStat or an EPOC. They can be measure of your resuscitation, but they're really lagging indicators. You can have somebody who is, in profound hypovolemic shock from blood loss, and they haven't equilibrated their hematocrit and their hemoglobin, and it looks relatively normal. That should not deter you from giving them blood. And I think any trauma surgeon, anybody who deals with trauma surgeons on a regular basis, is if the patient, is in shock and unstable from blood loss, you give blood. You don't look for a lab.
Mm-hmm. Okay.
It can be a sign of slow blood loss. We had a patient last night with a GI bleed who came in and her hemoglobin was 5, but that hemoglobin didn't get there, right away from a GI bleed. She'd probably been having a GI bleed for weeks. And finally her hemoglobin got to the level that, she had symptoms and came to the hospital. But that is not a situation that we see much in a deployed environment.
Okay. So how about, things like renal labs, like creatinine or things like that?
Again, helpful. There's helpful for gauging the extent of kidney injury, but our clinical indicators of kidney injury specifically, they're not making urine, they're oliguric. I think are just as good. And again, you can have somebody with a creatinine of 7 who's making urine. Our anemic. So we had another patient last night that was the case. And you can have a patient with a relatively normal creatinine, well, not normal, but lower elevation in creatinine, who's not making urine at all, and that's far more concerning. So, in the acute setting, with resuscitation, creatinine doesn't help as much.
Okay. All right.
I think more useful information for kidney function in the deployed setting is the urine dipstick showing the presence of blood in the urine, which is a surrogate for myoglobin, which is, going to be one of the aspects of rhabdomyolysis or crush, which is traumatic rhabdomyolysis, that is most concerning and leads to severe kidney injury.
Okay. What else we got? Glucose. I mean, that's an easy thing to bring along.
That's a great thing, and that is absolutely should be at the top of the list, because in the differential of any unresponsive or altered patient is going to be alterations in glucose metabolism. Typically, for our population, because we don't deal with a lot of diabetics, it's going to be hypoglycemia. So you're right. Probably the first lab that we grab on any ICU admission of an unstable patient is going to be a point of care glucose.
Okay. So, I mean, so far we got a pretty small list there, Doug.
Well, you don't need many, honestly. We send out obviously a long list of labs, but the ones that we focus on are pretty much the ones that I told you about. Are pretty much the ones I told you about.
Right. So, I mean, that's also very helpful, because you don't need to pack every single or order every single canister or cartridge that they have. You pick and choose which are going to provide you the results that are going to actually help you move your patient forward, not just give you more numbers to worry about.
Right. And, potentially distract you from, the important stuff, and treat things that don't need to be treated, or miss things that do need to be treated. And the good thing is that, reviewing the cartridges from ISTAT and the cartridges from EPOC is that now EPOC it seems to have one cartridge with, a pretty decent spectrum of labs. All of the important ones are included, or at least the important ones I talked about are included. ISTAT's a little trickier because they've got a ton of cartridges, but the CG8 is the one that includes, pretty much all of the important ones.
Yeah, perfect. So I guess since you brought it up, let's talk about, how do we go about collecting these labs? I mean, can I just draw from, the blood from an IV that I'm starting?
Correct. You want to make sure whenever you do a lab that the blood that you're drawing is actually the patient's blood and that it's not mixed with anything that might still be dwelling in that IV. If you've disconnected some IV fluid or if you've just pushed a med through there, you want to make sure, to flush that IV with first, to dispel anything that's lingering in the IV into the bloodstream. Then you want to draw, a few cc's of blood and waste it to make sure, again, that there's nothing that's lingering there, and then draw your lab. The cleanest way to draw labs is to just do, a fresh stick where, you're putting a needle at the end of an IV and inserting it into a vein and drawing directly from the vein. Neither is bad. It's just there's a few more caveats to drawing blood for labs from an existing IV.
Okay. Now, is there any real difference between an ABG and a VBG?
The biggest difference is that you're not getting PaO2, an oxygen level, partial pressure of oxygen with an ABG. I'm sorry, with a VBG. Now, like I said, the peripheral pulse oximeter is a very good surrogate. There is a lab on a blood gas that's called an SO2 or an SaO2, which is the arterial saturation of oxygen, as opposed to the one that you get from a pulse oximeter, which is a PaO2, a peripheral oxygen saturation. Both of those match really pretty well as long as you are able to pick up a good signal with your pulse ox. Now, where a PaO2 can be helpful is in a patient who's really in profound, shock that's vasoconstrictive, so hypovolemic shock, cardiogenic shock, where, the blood vessels clamp down and shunt blood away from the periphery to the vital organs. You may not have enough blood flow to pick up a good pulse ox signal. And so that's where your PaO2 and really specifically your SaO2 can be helpful.
Okay. Yeah, very good. What about actually collecting the sample? So we talked about drawing it out of a syringe. I know the iStat that's the only one I've ever used, and that was in a hospital. So we did an ABG. We actually took it straight from the artery. But it's got these stupid little pipettes that it is freaking impossible to get a sample, it seems like, to go up this little pipette so that you can feed it into the machine. What am I doing wrong?
Well, actually, just to go back, and again, that's a good point that you made with the difference between a VBG and an ABG. The ABG has to be an arterial blood sample, so you're not drawing that from a peripheral line. You're going to have to stick an artery, and that may be a skill that just doesn't get practiced enough to be practicable. So the other point I wanted to make about the difference between the two is really that the pH and the PCO2 are close enough between a venous sample and an arterial sample as to be not that important. Yes, there are differences, and some people will make more of them than others, but you can get a very good, you can, and we frequently do get a very good indication of somebody's acid-base status and their PCO2 from a venous sample.
And some of the machines will even convert it.
They will.
Through an algorithm. Correct.
Yeah. But again, anything that's derived, anytime you have to make calculations, you can introduce measurement error. Whereas, that you're getting, and both of the cartridges will tell you, what are our directly measured values and what are our calculated values. And you should have more trust in your measured values than your calculated
values.
Right. So as far as loading these machines, it is tricky. I think the best way to do it is if you have a small syringe, like an insulin syringe, that can more accurately dispense your blood. That can be helpful. But yeah, they are finicky, and that's a known problem with the machines. They talked about a paper that I sent you on a comparison between the two systems that a big EMS system in Canada did. That was a pretty well done study with very experienced paramedics and a good sample size. Hundreds of patients for each machine. Noted that the Epoch had an almost 40%, initial cartridge introduction failure rate, and they needed to be reintroduced. That was kind of news to me because I think of the iStat, which is what I have experience with, and what all the hospitals that I've worked in is. We think about that as being pretty finicky. So, you should probably, for planning factors, budget, double the amount of cartridges you think you're going to use, and plan on wasting 50% of them. And if you have less, then you're in the good.
Right. Well, I mean, also, how much of that is just user error because of inexperience? Well, I imagine through the study they got better at it, right? But you know how it is, like the first time you're doing it, you're like reading the directions and things like that.
Yeah. Yeah. Well, that kind of brings me to a point I wanted to make, not so much about labs, but about the whole idea of point of care testing and special operations. These are not cheap machines. The Google price of an iStat is $6,500. Now I know with purchasing and discounts and volume discounts, it's probably going to come down. But you're looking at one of these machines potentially being as expensive as a point of care ultrasound system and a good ventilator. Like an impact ventilator.
Mm-hmm.
And if you were to ask me, would I rather spend that amount of money on a lab system or a ventilator and an ultrasound? The answer is easy. It's door number 2.
Right.
Now, if you have your ventilator and your ultrasound and the resources to advance your diagnostics with point of care labs, then for sure do it. But put that into perspective. On a 1 to 10 scale, with 10 being the most important, ultrasound's probably a 10, ventilator's probably a 8 or a 9, and labs are probably a 2 or a 3.
Mm-hmm. Yeah. So that was actually kind of a point of contention when we did our review, our equipment
Mm-hmm.
review, is the docs were saying if you're going to have a ventilator, then you have to have, some kind of point of care testing. Essentially because I don't trust that you know how to adjust anything.
I disagree with that because I think you can adjust a ventilator just fine with an end-tidal CO2 and a pulse oximeter.
Yeah, I think you can if you are switched on enough to know, globally, what the hell is going on.
Well, the lab is not going to give you any different parameters. It's still going to give you an oxygen saturation, and it's still going to give you, a CO2.
Right.
Now, the CO2 is more accurate, is more physiologic on a lab than it is as an end-tidal because because the end-tidal CO2 can be affected by circulation, right? If you're not perfusing the blood vessels in the lungs because your cardiac output is low, then you're not going to be returning, carbon dioxide to the alveoli to then vent out and be measured by an end-tidal CO2 monitor.
Mm-hmm.
We had a patient earlier this week who was in just profound cardiogenic shock. I mean, his ejection fraction was like 5%, and he was on, we wound up putting him on a ton of mechanical support. And initially his end-tidal CO2, remember normal PCO2 is 40. So that's the partial pressure of oxygen in your blood. Well, his initial end-tidal CO2 was only 11.
Mm-hmm.
That didn't mean that he had a a bad respiratory alkalosis, it meant that he just didn't have enough circulation through the pulmonary vessels to get that blood through the pulmonary bed into the alveoli and out to be measured as an end tidal. As his cardiac output improved, his end tidal CO2 improved.
Mm-hmm.
That's one of the reasons that they talk about a good end tidal CO2 waveform during CPR as being an indication of good CPR. It shows that the CPR is circulating blood through those pulmonary capillaries. So I guess I would partially agree with the experts that you talked about earlier in terms of needing labs to manage the ventilator. CO2 is helpful and perhaps more necessary than PaO2.
Mm-hmm.
But again, you can do a fine job with either.
Right. I think it's if whomever is using the equipment,
Mm-hmm.
I think just like anything else we do, you can't look at numbers in silos, right? Everything is in context with everything else, right? So
Right.
like understanding that end tidal CO2 is going to differ from PCO2 because of problems with the respiratory system. Maybe it's
Right.
they're in shock. Maybe it's he's only has one functional lung because of trauma or atelectasis or whatever it is, right?
Mm-hmm.
But the closer you can get them, I guess the more healthy you can get, the closer you can get them back to normal, then the more these two things are going to mirror each other, right?
Right.
So I don't think it's unreasonable. I definitely understood why the physicians were saying that they wanted it for their guys.
Mm-hmm.
I think it's more of a telemedicine safety blanket thing.
Mm-hmm.
Somebody's calling me, telling me they don't know what to do. They have these lab values, and hopefully I can trust that they did it correctly. And through that information, I could probably more accurately help them. You know what I mean?
Correct. Right.
But that being said, I would much rather let them have an ultrasound, much rather have them have a ventilator and actually know how to use the two of them than I would point of care. But those things are getting a lot more common than they were even 1 or 2 years ago.
Right. And the point I wanted to make, in the acquisition process of these, kind of speaks to your comment about user familiarity and the reduction of errors and equipment malfunction with the machines. And that is, we have environments in special operations medicine where we could test these systems, on a relatively daily basis, and see, number one, to both evaluate the two systems, and number two, to build competency among the medics and the docs and the PAs, and that and those environments are, the battalion aid station or the equivalent thereof in the other branches.
Mm-hmm.
I would recommend, if that's something that we're looking at pushing out to the team level, before we, made that big investment, put them in every tech set or team equipment equivalent, put two in every aid station and use them in regular practice, and the medics could rotate in and draw labs and troubleshoot the machines and get their values. Number one, it'll be useful in clinical practice because you get heat exhaustion, on a pretty regular basis. And then all the other numbers, you can just use for training purposes.
Mm-hmm.
And then as competence and as competency grows, you can potentially field them more widely, but make a better decision about which system is better, because I have a pretty good idea that we're not going to buy both systems.
Right. Right. One of them's going to win the day, and generally it's not the medics that have the input on which one.
And if you have 2 or 3 in the aid station that the guys can practice on, and then you have a backup, if the machine goes out of calibration or needs servicing or whatever, then you have an extra one that you could loan out to teams that are going on a deployment, and they can take it with them. And part of their pre-deployment training would be, to do some days in the aid station, drawing those labs, working with the machine, troubleshooting the calibration of the machines, because that's not trivial. There's a lot of frustration that comes with dealing with these machines that have been miscalibrated, and if it's not done right, it's a useless, 2-pound piece of plastic,
Right.
$6,000 2-pound piece of plastic.
Yeah. Anything else you'd like to cover with labs?
Not that I can think of. Anything you think I'm missing?
No. I mean, I think it doesn't have to be overly complex, but I would want to know, going on deployment, and now that we're getting rid of different gear because nobody's used it for I don't know, 30 years,
Mhm.
but we do want some kind of lab capability. All right, well,
Mhm.
where do we actually focus on? Because I mean, you can get labs for literally anything you want, but
Right.
if you don't know what you want, then you're stuck. You know what I mean? You just get the entire package because that's easiest. Maybe let's be smart about it and say, be more targeted on what exactly matters for our environment.
Right. And that was, what I was thinking about when you asked me on the podcast, and as I was reading about the systems, and thinking critically about how we use labs in our practice. And, obviously from the stories I've told, we had quite a few patients just in recent memory where, I could look back on the resuscitation in the room of these unstable patients, and reflect on, what did I want to know first, and use that to help prioritize the recommendation.
Hmm. Cool. Well, thank you very much, Doug.
You're welcome.
Cool. All right. Have a good one.
Thanks, Dennis. You too.
That's it for today's podcast. Be sure to go to our website, www.prolongfieldcare.org. Find us on Facebook, YouTube, Instagram. Subscribe and stay on the bleeding edge of combat medicine. This is Dennis for the PFC Podcast. Out.
Boy, it's waiting there for you.